Welcome to the third of our fall 2022 HMEI Faculty Seminars. Today, we have a very exciting talk lined up. We have Professor Jessica Metcalf from the Departments of Ecology and Evolutionary Biology and the School for Public and International Affairs, SPIA. Jessica is a demographer, self-described that way, at least on the website, although she does go on to say that she has broad interest, and I think that is more relevant on ecology, on disease dynamics, and on policy. Jess, and here's a little learning moment, just completed her PhD from Imperial College on the evolutionary demography of, and this I didn't know what they were, so I had to look it up, and I'm going to teach you, on monocarpic perennials. Monocarpic perennials are, as you would know from the roots of the words, they're plants that flower only once, thus monocarpic, and perennials, so they live many years. I didn't know any of that, but I looked it up. An example is agave, correct? Is that what brought you to it, or anyway? So there, you've learned something already, and you're going to learn a whole lot more. Jess is a fantastic colleague. She is just a stellar scholar, just pushing in many directions, and a wonderful mentor. I can attest all of these from firsthand experience. And she is also one of the members of the HMEI Climate and Infectious Disease Initiative. And we are going to learn a whole lot. So Jess, take it away.
Thank you all very much. So my little brother learnt to say, my sister did a PhD on the evolutionary demography of monocarpic perennials. What does your sister do? As a chat-up line, I'm not sure it worked. But today I'm going to talk to you about disease in motion and landscapes of health. And I'm going to cover some of the research we've been doing in Madagascar. Because Madagascar sits to the bottom right of the vast continent of Africa, it's easy to overlook the fact that it is huge. It's the fourth largest island in the world. It was first peopled maybe 2,000 or so years ago from people coming from Indonesia. There were waves of people coming from Africa before and after that. Madagascar did not escape colonization, and in the late 1800s, through a series of bloody repressions, the French took over the island and almost immediately started on infrastructure projects. So, for example, they built a railway line from the high plateau where the capital city is found down to the coast. And almost immediately, malaria moved from the coast up to the high capital. This is a paper from 1903 in the Journal of Tropical Medicine and Hygiene. So the intersection between movement and disease has very long roots in Madagascar. Subsequent to independence, which happened in 1958, things did not go terribly smoothly. The gross national income per capita is not a perfect measure, of course, of anything, but it gives a sense of the degree of poverty in the country, and this rose starkly as incomes fell, rising a little bit only to be dropped back down in the wake of different political crises. Madagascar is amongst the poorest countries in the world. These are 10 of the other countries in that same category. And one sort of happy thing is not the right word, but one good thing is that Madagascar, and one surprising thing, is unlike all these other countries, Madagascar has never had a major bloodthirsty conflict. And another good thing is that Madagascar consistently outperforms other settings in terms of life expectancy, these other poor countries. And this is probably partly due to this eliding of these major bloody conflicts, but it also might be to do with successful battling against infectious diseases. There are not incredibly good data on causes of mortality across the country, except for in a couple of the big cities, including the capital city. And with colleagues, we looked at the pattern of mortality over the course of the year, so in the late 70s and the 80s and the 90s, and you can see that as you move forwards in time, the seasonal swing flattens out, which is a good signature of declining seasonality is highly suggestive of success against infectious disease pathogens, things like influenza, things like measles, that tend to surge in winter. Despite this success, and it is well known that the vaccination programs have been incredibly effective in Madagascar in many settings. But despite this, there have also been enormous setbacks. There was an enormous measles outbreak in 2018 that killed at least 1,200 and probably many more children. The causes and the ways in which this landscape of health are defined is in part probably due to the fact that Madagascar is a place that it's very hard to get around. These are the major roads shown here. It remains extremely hard to get from Majanga to Maintarano unless you go through the center of the country. This probably had a lot to do with why the measles outbreak took so long to happen and was so large when it did, a story which we've probed in other settings and I can talk about more if people are interested in. But today I'm going to take a different tack and talk about 3 different stories within the context of connectedness and health in Madagascar. I'm going to talk about access to care with the example of rabies, exposure to infection, and the movement of livestock. I've chosen these partly because HMEI funding has been instrumental in allowing much of this research to happen. Rabies is perhaps the ultimate example of the situation where access to care is enormously important. If you are bitten by a rabid dog, you have to get post-exposure prophylaxis or you will die. And this is really well known. So even in Madagascar, if you have been bitten by a rabid dog, it is reasonable to assume that you will make every effort to get to care. Malavika Rajiv, who is a PhD student here, took data from, there are 32 anti-rabies centers across Madagascar where they will provide you with this care if you get there. And she had information on the flows of individuals going to these different centers, shown as these circles. And you'll notice, perhaps by just squinting at these maps, that it looks like, based on these circles, based on these flows, that most rabid dog bites or suspected rabid dog bites are happening close to the centers. Unlikely, isn't it? It's probably to do with the fact that even if you are bitten by a rabid dog, even if you know you are likely to die, you just don't have a way of getting to these centers where you can get this life-saving shot. How can we actually quantify this and get to grips with this information? Well, you need to know how hard it is to move around this landscape. Various efforts have been made to this end. So, for example, the Malaria Atlas Project and WorldPop have put together what they call friction surfaces. So every cross here shows you one of the Madagascar anti-rabies centers where you can get free care, a free shot if you've been bitten by a rabid dog. And then the colors, the darker colors, indicate places that it's harder to get from. So there's less, this is based on things like Google Maps and pulling together information on the roads, pulling together information on the terrains, using machine learning, and trying to come up with a sense of how long it takes to get places. Mal is a deeply cynical person, and so she looked at this and went, really? And decided that she would probe the evidence. And so she put together data on actual driving times and compared it to the estimated driving times from the Malaria Atlas Project maps, and also just patient-reported times as well as driving them herself. And the correlation isn't perfect, but it's reasonably good, and the exceptions were ones that made sense in terms of how she knew the landscape. So with this in hand, what she did was she's plotting now travel time, so how long it gets to take to the center, against what this data set on people turning up at anti-rabies rabies treatment centers tells us about how many dogs have happened. So you still see this really, dog bites have happened. You still see this really striking pattern where it looks like most rabid dog bites are happening really close to the anti-rabies centers. This is obviously not true. This is obviously the footprint of people struggling to get to care. With this map in hand, what you can do then is you can figure out where are the people who are most at risk? Where are people, assuming that rabies is evenly distributed across the country, which we know is untrue, but we have no better way of getting at this. But if you make that assumption, you end up with a clear indication of where people might be most at risk. And what you can do next is you can start saying, okay, then where should we be putting new rabies treatment centers that will most diminish, most alleviate the burden of this really excruciating form of death within this population? And many people are still bitten every year. As a side note of part of her project, Mal actually showed that you can do very effective dog vaccination campaigns. This is really what you should do, right? You should be eliminating rabies from the island of Madagascar. It's an island, it should be straightforward. But there was no proof of concept that you could vaccinate dogs effectively until Mal did a couple of projects on this as an aside in her incredible thesis. But the real take-home here is that access to care remains a major barrier to health. There is no more striking evidence for this than people not getting care subsequent to being bitten by a rabid animal. This is also something we've seen in looking at vaccination against measles. So this is measles vaccination coverage against travel time to the nearest city of 50,000 or more people. And this also connects to the next part of the story, which is about human mobility. So it's obviously really not great that children who are living more than 8 hours away from a city of 50,000 or more people are not having the opportunity to be vaccinated, or only 40% of them are. But what's even potentially more confounding is if these children are all located in the same sort of area. So the greater the level of aggregation, the increasing the degree of clustering, the greater the outbreak risk. If we had one unvaccinated person in this room, that person would be at a very low risk, because I'm imagining that almost all of us have been vaccinated or had the infection. If you have a vast number of unvaccinated people clustered together, if an infection gets in, that geographical proximity matters. And in Madagascar, the situation was complicated by the fact that it seems that these vast susceptible groups existed, but were not so well connected between each other, which allowed this enormous delay before the big outbreak happened that then killed so many children in 2018. Which brings in another thread of how we think about how motion, mobility, human mobility intersects with infectious diseases. It's not just access to care, but it's also the fact that we ourselves are moving the infection around the country. The degree to which we connect different settings will shape the degree to which the infection can move. This is obviously was relevant in the context of SARS-CoV-2. You may all remember in 2020 when we were all gloomily staring at the Johns Hopkins maps. And for a very long time, it looked like there were very few cases occurring in Africa and in sub-Saharan Africa. And many extreme narratives started floating around. People said, well, it's not going to be a problem because there's such vast experience in dealing with infectious diseases in these settings, or there's some circulating mystery thing that will stop people from being infected because they're immune against it, or who knows. But frustrated with these very extreme and sort of fairly simplistic narratives, Benny Rice, who's a postdoc at Princeton, put together a team from different universities across sub-Saharan Africa to think about this question. And the very first thing that pops up when you do this is if you look at international travel into the continent, more flights come into LAX in a year than into the whole of the continent, well, the sub-Saharan part of the continent. So it's not actually that shocking. There was a delay before we started seeing the circulation of SARS-CoV-2 in sub-Saharan Africa. It's just not that connected. You don't need to invoke magical immune systems or something random to bring it together. And of course, once SARS-CoV-2 got there, using estimates like that friction surface, it'll take quite a long time to get to places within the country just based on the fact that within separate countries, just based on the fact that connectivity is extremely heterogeneous. And just as an aside, even if you were to neglect this aspect of connectivity, there is, of course, tremendous diversity across sub-Saharan Africa in terms of demography. If you make the simple assumption that 40% of the population is infected and use the classic infection fatality ratio across age that was documented very early in the pandemic, what you see is tremendous variation in burden because there are places in sub-Saharan Africa where populations are old and places where they are young. And it really makes no sense to make vast statements about Africa. Over the course of this 2020, Fidissou Razambainarive was frustrated by the fact that in Madagascar there was absolutely no publicly available source of information on SARS-CoV-2, so he pulled together a team of mostly veterinarians, because that's what he is, to collate data on the number of cases from Facebook, from the radio, and put together what became the dashboard for Madagascar, maps of where cases were occurring, the time series, and everyone was consulting it. UNICEF was calling me and saying, so, and I was like, well, I talked to Fidi. And in parallel, we were also often on the phone with the Ministry of Health and other settings asking, whether there was any piece that we could support, whether we could start trying to anticipate where the infection was going to go next, right, in order to distribute resources, etc. What would happen was everyone would be absolutely in favor of us and everything we could do and say, but we just have to talk to one more ministry. So there'd be another conversation and nothing would happen. But by 2021, we realized that although we had not been able to work to help anticipate where things were going, we could look retrospectively to see how well we would have done, because we had the time series of cases from PD's work. And so what we did, and this was work led by Tanzania, Rami and Tsu, was pull together a set of different models of how people might move around the country and see how they lined up with how the disease, based on the data that we had, moved around the country. So you could have a really simple null model, where you assume that people have an equal probability of moving between all the regions. You can say that it's Euclidean distance and maybe population size matters. You can go and talk to bus drivers. Tanzania, for some reason, loved doing this. And get to grips with that as a metric for reducing travel between different settings. You could use those same friction surfaces that Mal used, or you could use mobile phone data. And this latter you could use because we happen to have mobile phone data, because we'd used it in a previous project. Just to give you a brief insight into how this works, every time you make a call, that call is routed through the nearest mobile phone tower. And if you have the call data records, so-called, which is basically the billing records, they say where that tower is. So you can back out how people are moving by using just simply the billing records that are sitting with the operators of these mobile phone companies. And of course, I'm sure you're all thinking, this is unbelievably creepy. It's true. But the way we usually do it, and we've used this in many settings, is you need buy-in from the Ministry of Health, you need buy-in from the operator, and you need buy-in from the regulators. And then with all that in place, what happens is that one of your team goes and sits in the operator's headquarters and aggregates the data to the scale that we're interested in, so no personalized information ever leaves the building, which also means that we have no information apart from who's going where. We know nothing about age, etc. And we thought, but we do have a really remarkable insight into fluxes of people across the country. And we're hopeful that this might be useful information because we've used it in previous sets. So this is what that looks like, by the way. So it's a really detailed map of how people are moving. And we were hopeful that this would work reasonably well to get a sense of how this infection was moving because we'd used it in previous settings. So for example, this is data on rubella in Kenya, completely immunizing infection, 3 peaks in every year of the data, which maps, as Amy Wazlowski showed, very clearly to patterns of travel. So you see that for some reason, there's vastly seasonal patterns of travel that absolutely echo seasonal patterns in transmission. When people are moving a lot, there's less transmission. This makes sense. People are moving away from each other, so there's less opportunity for transmission for this directly transmitted infection. And this was consistent across all the different regions of Kenya. So something, we're capturing something with this. And we'd also done some work, this is work on the movement of malaria in Madagascar, where we'd ranked all the possible sources of malaria, both by how much parasite we suggested was going to be there, and then how much people left these source areas to go into the capital city where there's very little circulating malaria, and then plotted those sources, those predicted sources, against the rank of where the data suggested that these infections were coming from. So this correlation is not perfect, but again, it suggests that this mobile phone data is giving you something, giving you some window onto how the diseases are traveling around this landscape. So Tanzania took all those different models of mobility, simulated a stochastic epidemic, the arrival of SARS-CoV-2, and it spread across Madagascar, and it did terrible. So they all just look very disappointing. This is the first reported case or the 5th reported case. This is the correlation between the simulation and the observed. Nothing was great. This is one of those situations where the title of the paper means that you don't have to read the paper. Of course, there's many reasons that might be the case. It could be that the data was terrible. We know the data was terrible. The SARS-CoV-2 data was collated very much on the fly. It would have been much better if we'd been able to get serology data or other sources of information. But it's also the case, and I think this is something that all of this data, this research into mobility has to grapple with. We don't necessarily know that we're measuring disease-relevant movement or disease-relevant contacts. So the rubella example probably works quite well because this is quite a transmissible infection moving in an endemic setting. So it's at equilibrium. No one vaccinates against rubella. There's regular repeated patterns year in, year out. We can probably pick up what those vast flows of populations are doing to the infection. The malaria case as well is one where there really isn't very much malaria on the high plateau at the moment. So we have a fighting chance of picking up this very striking infection and those movements that are bringing it in. just about any other example you can think of, the data will not be as good. There will be heterogeneity and immunity within the population that you won't have information on. And then you don't know whether the movement, if I go to Baltimore, it's not clear that that movement, mobile phones are often owned by adults, many infections are moved by children. What really are you getting at? But clearly it's helpful in some settings. Okay. So we've talked about access to care. We've talked about people moving around landscapes and how that might move infections. I'm now going to turn to talking about livestock and how livestock moves around landscapes. This is work that we started, again, Fidi led this work, looking in particular at poultry. And what I'm showing you here is the distribution of where people tend to own poultry, and then the number of poultry owned by people who do own poultry in 2008 and 2021. In rural settings. Not much change in rural settings. In urban settings, it's quite hard to see, but there's been an increase between 2008 and 2021 in the number of chickens that people own. And we were interested in this particularly because, at least in some situations, much of household income can come from these sort of urban backyard farm situations. Up to a fifth of household income may in some situations be sustained by these sorts of practices. So this was what we were going to dig into, and we did it in part, we were supported here by an HME funding towards urban sustainability. And we were asking, how does the small bird live farm market intersect to shape pathogen spread and pathogen evolution? This is Antananarivo, the capital city, where we did our first set of analyses. And this is one of the live bird markets in the capital city, showing the location of the different live bird markets. And then what Fidi did was led a team to go and talk to the people at these live bird markets, this is Wudzu and this is Santacha, and also take samples from these chickens to see whether they had any diseases. And the first thing we discovered, remember I was really interested in this urban agriculture question, was that these chickens are coming from everywhere. They're not just local chickens. And in particular, these ones just shocked me because this is 5 days of driving. So I'm still just absolutely puzzled by this pattern, and we haven't really got to the bottom of it. But it does suggest that understanding how poultry pathogens move around this landscape probably entails not just understanding what's happening in any city, but understanding what's happening at the landscape scale. And indeed, if you look at the different markets and look at the number of districts they're sourcing their chickens from, the more districts you're sourcing chickens from, the more likely you are to have these two poultry pathogens, which are the 2 that we tested for. Newcastle's in particular is one that is vaccine preventable, and so we were particularly interested in trying to think about whether this structured population, the structure of transmission might tell us things about where vaccination efforts should be concentrated. In parallel to this took us down a road, and this is something that Justin Sheen has been thinking about, which is what does it take for these markets to actually amplify the spread of infections? We think about this more and more in the context of avian influenza, but what are the exact dynamical characteristics that make a location, a market location, somewhere that amplifies infection, somewhere that might be a hub for evolution, etc. And these questions matter because we live in a changing world. This is what happened in 2019. This is the president of Madagascar, and this is Kentucky Fried Chicken. So Kentucky Fried Chicken opened in Madagascar in 2019. President of Madagascar, who was at my high school and was not great then. Still not great. But it's clear that he doesn't love Kentucky Fried Chicken, at least based on that picture. But clearly, the existence of Kentucky Fried Chicken implies a vastly different chicken rearing context, right? Which definitely implies a different chicken pathogen context, etc. So as we step into this changing world, and changing not just in terms of numbers of flights, this is in a paper that Rachel Baker led on how infectious diseases will exist under global change, but also changing floods of goods across different contexts, we have to start thinking about what this will mean for the future of pathogens. And as an example, African swine fever is something that has been of enormous concern around the world in recent years. Huge, it's not flocks of pigs, but you know what I mean, huge pig farms culled to try and control this infection. And in the outbreak that occurred in 2007, was introduced into Europe in 2007, the first big outbreak since the 1990s, had genetic similarity to pathogens found in Madagascar, Mozambique, and Zambia. So this implies that understanding what's happening in these settings has potentially global food security relevance. In Madagascar, people don't own that many pigs, but that is not to say that that couldn't change dramatically. So many things are changing dramatically in these settings. So I've spoken about access to care, how hard it is to get care, how movement around the landscape might move pathogens, and how hard it is for us to grapple with that. The movement of livestock and the sort of surprising different distances that livestock travels. I'll just give you one more story now, not on livestock, but on companion animals, so thinking about toxoplasma. So this is a pathogen which is one of those weird pathogens. It's not a bacteria, it's not a virus, it's protoplasm. It completes its life cycle if a cat eats an infected animal, and then the cat produces oocysts in its feces, which are eaten by these animals, etc. And the reason we care about this is that this is something, these oocysts can be consumed by us. If we eat animals, these oocysts turn into tissue cysts in sort of any, it can't complete its life cycle in anything other than a cat, but it happily infects just about any vertebrate as far as we can tell. And this potentially has conservation implications, and it also has health implications in people. And so you might be thinking, Jess, how in the world are you going to turn this into a disease in motion story? I can, because if you remember, Madagascar has nothing in the cat family that's endemic. It has 3 carnivore species that are descended from civets, but that's it. There is no reason, historically, for Toxoplasma to be in Madagascar. But of course, Toxoplasma is in Madagascar, and that's because there's a lot of cats in Madagascar. The cats probably came in over, I don't know if it's as early as 2,000 years ago, but a long time ago. And there certainly has been a group of cats that actually is happily living within the forests of Madagascar. They look exactly like tabby cats, but a little bit bigger. And they've been there about 1,000 years, we think. And they came over, they're most closely genetically related to Arabian cats. And they're, of course, murder to the birds, as cats always are. But they also are allowing Toxoplasma to persist in these environments, which is of concern because we don't know what that'll do to these weird and fantastic carnivores that are highly endangered in Madagascar. This is Cryptoprocta ferox, the fossa. Part of what we've been doing is looking at the serology of these carnivores within reserve areas which we would think would be remote from cats, and still finding that they are seropositive. They're definitely infected. What it's doing to their health is not clear. We're also thinking about what this means in terms of human health. So the particular concern in people is that if you're infected during the first trimester of pregnancy, you can have very severe birth outcomes. And so this is one of those interesting situations where if everybody's infected very early in life, then they're never at risk of having that first infection during pregnancy. But if you reduce exposure, then you're going to have a window where you're actually making it take longer before you get your first infection. So you might be increasing the burden associated with problematic health outcomes associated with toxo infection. Obviously, if you get rid of toxo, you don't have a problem, but there's an intermediate increase that will occur. Okay, access to care, exposure to infection, movement of livestock and animals, all of these things, as I mentioned, are things that pattern of connectivity across Madagascar is changing vastly. And we are not, of course, in the business of building roads. That's not what we do, but we can start to identify where there are points that we should strengthen surveillance, where there are warning signals that might be arising, where vaccination might be happening. And although, fundamentally, this, as in every other public health problem, the answer is strengthening infrastructure, strengthening surveillance, making vaccination available, widely available, sick leave, etc. On the path to that improvement, there are still things we might be able to do to avert, for example, outcomes like the very serious measles outbreak that occurred. This is something that one could have anticipated if one better understood this landscape ahead of those generalized improvements that are, of course, necessary. And in anticipating these sorts of severe outcomes, another one that, of course, springs to mind is the disruptions due to extreme weather events. Madagascar is constantly being pounded by cyclones. This was Tropical Storm Chesda, which we had the mobile phone data so we could see people actually moving out of districts that were affected. You could get a sense of where they were going. But you also know that this is disrupting access to care. This is increasing risk of infection, and so on. In February of this year, looking nervously at Gabe, I think 2 cyclones hit Madagascar, all within the month of February. And this is something that Ben Rice is working on, sort of pulling together data to try and figure out what the consequences are, and then also think about ways in which you could build in resilience as you anticipate these outbreaks coming in. So that's it. I want to really acknowledge, first of all the first authors of this work. So Fidi, Tanzana, Felina, Mal, Benny, Rachel, and Justin have been really leading the charge on many of this, supported by huge numbers of co-authors. The Center for Health and Wellbeing funded all of our work on the rabies, and much of the work that we pivoted towards to meet SARS-CoV-2. And HMEI has funded everything we've done on chickens and everything we've done thinking about toxoplasma. So thank you to them, and both those latter projects were supported by vast groups of HMEI interns that helped us collect much of the data that I've presented today. And I think since we so rarely get to do a home court presentation, I also want to say just over the last 2 years, the disease group and the climate and disease group in Princeton has been really extraordinary. And I'm sure you know the papers that were published are all on public view, but huge amounts of work also went in terms of reviewing papers, in terms of sitting on calls to try and support various efforts towards that end. So I just wanted to say thank you to those people as well.
Okay, so just as a reminder, we're going to ask for questions from the audience in the room, but we also have the ability for those of you zooming in to put your Q&A, and I will relay them. For those of you asking questions in the room, put your hand up, and then we'll call on you, and then somebody will get a mic to you so we don't have to repeat your question, okay? So we'll start. Any questions? Oh, wait, Brian first. And I would also like to encourage the first question to come from a student. We have a question here. And then Brian can ask a question.
Hi, Jess. Thank you for that awesome talk. So I know that Madagascar has a pretty defined topography with like the escarpment to the northwest of the country. And I was just wondering if you see any evidence of that physical topography potentially mediating movement dynamics, human movement dynamics, and then also having an influence on how disease is transmitted across the landscape.
So it definitely really matters, obviously, for the diseases that hinge on mosquitoes that like the coasts more. So you get this gradient where you really don't have continuous malaria outbreaks on the high plateau. If you look at how people are moving, it really does look a lot like where the roads are. There's sort of, just a couple of big hubs and people move between them. The finer scale of the degree to which the escarpment might be blocking access on the smaller roads is not something we've grappled with, but that's a really interesting question.
Now we have Brian. I'll bring you the microphone to make up for it.
That was fantastic, Jess. So in terms of the cyclones, I know Benny is doing amazing work on this. First of all, what do you think the proximate effects on infectious disease transmission, if any, there are other cyclones? And is vaccination reasonably robust to the cyclones, or are there problems in that sense as well?
Two great questions. So Benny has been working on this. Our expectation was that the three things could happen when a cyclone hit in terms of malaria. Nothing. It could be that the malaria incidence actually went down because the mosquitoes are washed out and can't persist, or it could be that malaria incidence goes up because mosquitoes are doing better in these disrupted environments. The lens you have to look at this is extremely complicated by the fact that if you go out to survey for malaria incidence, you have to treat people. So you have a background of declining incidence come what may, because there's no way you're walking away from someone who has malaria. So the longitudinal data we have, and this is Benny and his team, it just shows this declining pattern, and if anything, is sort of flattening. It's hard to pick apart there are reasons to expect various levels of outcomes, but we have no strong evidence that anything other than sort of more of the same is happening at the moment. In terms of what it might do to other infections, I think there's no question but that cyclones could disrupt delivery. So they disrupted delivery of bed nets. That seemed to be one of the issues that might have explained some of the bumps in malaria incidence. It also does disrupt vaccination, but you have this funny system in Madagascar, which is not how it's supposed to be. It should be that childhood vaccines are delivered when children reach the age for routine vaccination. But in Madagascar, in fact, vaccines are mostly delivered in 2 weeks of vaccination, semaines de vaccination, that flank this hurricane system. So I think that's sort of probably curiously robust to the hurricane system, unless the timing of the hurricanes moves, which might be problematic. I forget if there's another question.
So, Stefan. Oh, do we have one from a student? Maya. And then Stefan.
Hi, Jess. Thanks for a great talk. I've heard a lot of things about how with climate change, some island-type regions are worried about new diseases coming to the island. So is there anything like that happening with Madagascar?
It's kind of mysterious. So there's Esther Annan, who's a CHW postdoc, has been thinking a lot about, why is there no dengue or Zika in places like Madagascar, but also in much of sub-Saharan Africa. It seems like there's the right-ish mosquitoes, there's the right-ish climate, and every so often you get a little bit of a dengue blip in Madagascar, but it somehow doesn't establish, and that is surprising, right? And if you remember how the Zika outbreak played out, there was an outbreak in Yap in 2007. There's a small group of islands, and then it kind of traveled in these blips before it hit Brazil, and suddenly was this huge outbreak. So I think there's definitely, it certainly is the case, and it's actually a perfect question, right, Maya, in terms of that mobility intersection with diseases. These islands may have been sheltered for a long time simply by being that little bit more remote. And so certainly it's something to keep an eye on. Brian and I once read a paper showing that it is easier to control vaccine-preventable diseases on islands, even controlling for everything. If you compare them to other countries that are the same size, you do better on an island because you just have to, there's less influx probably. Madagascar doesn't have a vast, or at least no one's ever evaluated it, but HIV does not seem to be a big problem. At least you would expect to see, even though there has never been the survey that they should have been, you would expect to see a footprint in that life expectancy, which you don't see. Why is that? I don't know. But clearly, I mean, that would be a vast, huge, terrible thing if that was to suddenly become a big issue.
Stefan?
My question concerns basically what are the limits of that sort of field that you're working on? What is the limiting factor? So, you see kind of qualitative relationships. Do you think it's simply lack of high enough quality data, such that basically the conceptual model that you have would be accurate, but you don't have the data to really support that? Or is there something intrinsically chaotic also in these diseases that limits, even if you would have perfect data, the predictability?
I'm tempted to pass this to Brian, but I'll have a go. So data is absolutely limiting in this particular setting, and hugely limiting. It's very hard to say what's going on when you don't know who's being infected. But there's another vast bit of information that Brian and I have been pushing for a long time, which is, cases are fleeting and disappear, but you carry a signature of whether you've been infected or not for your whole life, right? I could figure out whether you're immune to measles or not by taking a drop of blood. And since this defines whether measles can spread or not, it's actually a huge part of the information in engaging what that future trajectory of the infection is. So the right kind of data would take us a tremendously long way, especially for the pathogens which have relatively simple life cycles. So measles is something where the entire life cycle takes about 2 weeks. Once you're infected, you will never be infected again. It's actually beautifully tractable in ways that, I should also say, can yield chaotic dynamics. But because it is a relatively tractable life cycle, we can actually predict when we expect chaos. And there's examples in Niger and examples in the United States, defined by the length of school times. It's very lovely, if you like that sort of thing. The chaotic dynamics aside, many other pathogens have much more intricate life cycles. So for malaria, for example, you can be infected, but not particularly infectious and not show any symptoms, and the degree to which you're infectious, there's many strains circulating. So although clearly more data would improve things, it's often hard to imagine that we at the moment have the ability to measure a fine enough scale of nuance to actually get to grips with all the things we need. Brian, would you add anything?
I think your ideas of global immunological, because the acute infection, they're so logical much. If that were available globally, it's like game trying to do its stuff. Crucial variable.
We have a question here and then another one there.
Hi, thanks for the talk. I was wondering about how the movement of diseases and how using phone data or other paths of human movement, has that been measured with like sexually transmitted diseases or other diseases, like not just rubella or SARS-CoV-2?
So the way the data I'm using works is it really just gives you a crude sense of what tower you were closest to. So given the number of individuals who are close to towers, it probably wouldn't be very good at capturing the detail of sexually transmitted diseases. And it also doesn't have, sexually transmitted diseases often hinge vastly on demographic characteristics, right? They travel through men who have sex with men, or they travel through different age classes. We're blind to much of that. I think one of the reasons that the mobile phones work so well for the diseases that Brian and I work with is that they're incredibly transmissible by people sitting together in the same room. So you don't need a sort of intricate, intimate contact, and you can capture those vast fluxes just by looking at fluxes of populations.
And we had another question.
Hey, thank you for your talk. I was really intrigued by the discussion of potentially like vaccinating all of the dogs in Madagascar against rabies. What are the primary obstacles to overcome for that?
Great question. So people used to think that it's like people didn't own dogs and dogs were all feral, but that's not really true, right? Every dog that's living in proximity to people has someone who associates with it and feeds it. The other barrier that people thought existed that Mal proved was not to be the case was that people might be reluctant to get their dogs vaccinated. So she set up a vaccination station and she has these pictures of people turning up with their puppies in baskets and their dogs over their shoulders. People are keen to get vaccinated, to vaccinate their dogs. I think the challenge is just the logistical challenge, right, of getting to all the people. But since rabies is actually has very low transmission, it's something that, it seems to be that on average a rabid dog only infects 1.2 other rabid dogs, right? Which is just tiny. So there's a long tail and there's a lot of heterogeneities, but with sufficient dog vaccination, it should certainly be tractable, I think. And you need a little bit more surveillance, but I think a targeted effort could be doable.
Yeah, Echo, thank you again for an amazing talk. My question, I was curious about the data you showed where you compared kind of seasonal migration and then the transmission of diseases. And naively, I would have thought that during periods of high migration is when you would have more transmission if people are moving towards urban centers and taking buses or collective transport. Could you say a little bit more about why it seemed like it was the opposite kind of effect?
It's a fascinating, so again, we have this we're curiously blind to whose movement we're capturing. We did an analysis of mobile phone data from Pakistan, Namibia, Madagascar, Kenya, and we showed that we were hoping for like a subtle climate signature. People move when there's droughts or something. What we found is that people move when schools are on holiday. Everywhere in the world, what happens is people travel when their kids are out of school. And since kids might be one of the core drivers of infection, that might be part of what explains, right? Kids going to school is certainly what drives measles outbreaks. It might be true for many other sorts of infections. We also showed, as part of this paper, that the worst possible time for a pathogen to emerge would be right around Christmas, because then everybody takes it home, so you get the biggest distribution.
So you showed the map of predicted rabies mortality. That was predicted.
Yeah.
Is there verification on that? is the mortality data match or no?
So there really is, cause of death data is extremely sparse. That's one of the reasons we had to do all those backflips, is because we don't actually know, what most people, who's dying of what, and like the parts on the map that were dark suggesting there was low access are parts where all other information is missing as well. We also believe it will be wrong, right? Because one of the assumptions is that rabies is evenly distributed across the country, and that is just not true. It's a very sporadic sort of outbreaky disease. So I don't think there's a way you could pin down that. It's our best guess on bounding risk rather than an actual prediction of what deaths might be.
And is there another place that is analogous to Madagascar that you could go and having the rabies or any of the other ones sort of make predictions about what you would see in this analogous place?
So my best friend did her PhD here. And one of the things that she showed was that it's really relatively straightforward to backtrack rabies outbreaks because people remember rabid dogs. So you can do what's called contact tracing. So you can figure out which dogs infected, which dogs were bitten by which dogs, and sort of build the chain. And she did this in Tanzania, and as part of these analyses are things that were analogous to things that we did, and rabies sort of looks like rabies, and it's often unobserved. So I think that the biology is reasonably well understood, and partly through her work, and nothing that we've seen is at odds with that, but we don't also have she has a vast team working, and we just had Mal.
Okay. So, yes, we have more questions.
Hi, I was wondering about the plots you showed with increasing flight patterns and exchange of goods and how that might affect disease transmission. Like on the one hand, it seems like it would introduce pathogens into new areas, but on the other hand, it might make the globe more homogeneous and eliminate the sorts of clusters which, you also argued create epidemics. So I was wondering if you had ideas about how those two competing forces might, play out.
So this is a great question. It also connects to what Brian was saying, right? Like the question is, what you're asking about is the maintenance of pools of susceptibility. I think it's very hard to predict what would happen unless we know where those pools are. And one of the ways we could get at this is simply by, you could take a drop of blood from everyone in this room and figure out whether they'd seen Bangkok 68, which is one of the big flu pandemics. So we could get a retrospective on what you'd been exposed to, but also what you were vulnerable to, and get a sense of how clustered those were in space. And it's also, it's relatively straightforward to do. There are vast blood samples. People go out testing for malaria or fever rash surveillance or HIV. There are blood banks. You could get this intelligence many, many different ways. And the technology is advancing, so you could actually test a single drop of blood for every virus that's been known to infect humans. There's only 200 of them, and they have tiny genomes. So you can break them up, put them on a chip, expose them to people's blood, and be like, oh, well, this looks like an area where this, that, the other is happening. So I think it's a data question, right? And it's one that we have the capacity to grapple with data. It's a really interesting theoretical ecology question as well, but the data is what will anchor it.
Okay, well, if there are no further questions, I'd like to thank Jess again. And I would like to remind you all that on December 6th, we have our fourth and final HMEI Faculty Seminar for the semester. Ellie Bouzaid from Civil and Environmental Engineering will be presenting on the urbanosphere, how humans, infrastructure, and nature shape the emerging environment of cities. So see you in December. Thanks.